You heard from Dr. Bannister about the pharmacology of the central nervous system, and now we're going to be talking about what goes wrong and how we can fix it. I'm not going to say it again, but replace the language. So, it's Friday morning, it's 9 o'clock, but you have like 50 billion neurons in your brain, so you're probably going to be okay for the next hour or so. They're arranged in highly complex circuits, and so probably one neuron has 100 contacts from others. And if you just kind of think back to the two peripheral nervous systems you come across, the neuromuscular junction is one neuron in your spinal cord going out to your muscles. Your autonomic nervous system are two neurons in a pathway going from the central nervous system out to your organs. So those are pretty simple systems. And in those systems, it's very easy to measure the effect of activation of those systems. For example, you could just look at a muscle contraction, you could measure heart rate, you could look at kidney output, you could measure a hormone in the blood. It's all really easy. But the minute we're in the central nervous system, which incidentally, don't forget, is the brain plus the spinal cord, it's both of them, but there things are much more difficult. Because how are we going to measure effects? Is anybody in pain at the moment? If you were, I would have no idea about how much pain you have, or equally how depressed you are, or anxious that this lecture is starting and it's going to be terrible, or whatever. And so there's a real issue. There's no objective measures we really have for CNS disorders. We rely on patient rating. So if you were in pain, it's a very simple thing. No pain is 0, 10 is the worst you've ever imagined, and you might say 2 or 7 or 8 or whatever. And the doctor would have to rely on you describing and telling them how much of something you've got. So if you're doing a clinical trial on a new therapy, your end measures are actually really difficult. It's not just like the heart rate go up, it go down. You're relying on complexity of the nervous system. And there are compensations. So the kind of good news is that if, as you get extremely ancient, some neurons in your brain start dying off, and you've probably now got more neurons than you're ever going to have, ever. I've obviously got loads. With time, the number of neurons drops off in the brain. They're basically not replaced. But pretty well, everything goes fine. Because the nervous system, because it's got so many neurons and it's got so many circuits, can compensate for some of these disorders. And the best example is Parkinson's disease, which is due to death of some neurons in the brain, and there you probably have to lose 80% of them before anything happens to your ability to move. So the remaining neurons can compensate for problems that go on. So there's your brain. It's kind of pretty impressive. And what we have in the brain are a number of events going on. We're all primarily responding to sensory inputs and life in the world around us. So none of you have got pain whatsoever, but your pain pathways are present in your spinal cord and brain. And if you have, fracture a limb, for example, those pathways become activated. We have visual inputs, we have auditory inputs, etc. And then we process that information. So we have cognition, where we kind of think and interpret what that means. We have processes of memory. We have emotional responses to what we see, hear, and taste. We make a decision on them. So we're probably already excited. This lecture is the best thing I've ever had, and we're feeling very happy and nothing depressed. We'll see later. But basically, we respond emotionally. So all that is going on in our brains, and all of that is personal and individual, and makes us who we are. But what do we output? What is the brain outputting? And it's actually ridiculously simple. All it does is control the body to keep itself going, so the autonomic outflow and motor activity. So the systems of the brain that are to do with moving muscles, we may have a sensory input, which could be this lecture is remarkably boring. There's a motor response, I'm packing my bag and I'm just going up the exit at the back of the lecture theatre on the left. But we primarily use motor activity for communication, for speech, for tweeting, posting on social media, sending a text message. That's how we communicate. And the problem here is that, let's say, a stroke. So a stroke is basically where neurons in the central nervous system die. So let's say it's here. We can see where that's happened. Basically, they've lost their blood supply, and so they'll die. We can see where it happened, but there's absolutely no way we have of knowing what neurons exactly were they, particularly in terms of their transmitters. So we basically can't treat stroke because we don't know what neurons have gone. We don't know whether we've lost glutamate or acetylcholine or something else. And so consequently, there's no pharmacology we can do on that. So disorders of the central nervous system. There are some principles. So homeostasis is balance between events within the body. The brain is exactly like that. So the reason you're all here is that your excitatory system's won out, woke you up, got your muscles going, and you arrived in the lecture theatre pretty much on time. And a few people who aren't here, they've still got inhibitions, they're still sound asleep in bed, and missing all of this fun. But basically, there's a balance. And the disorders reflect that pretty well. So on the left-hand side, we have pain, too much activity in the sensory pathway. Epilepsy, too much activity in the parts of the brain that control muscles. Anxiety, basically our moods are hopefully pretty okay most of the time, but too much activity in our circuits that are responding to external events causes anxiety. And schizophrenia. Schizophrenia is a mix. As you can see, it's on both sides. So the positive symptoms of schizophrenia, the most common one, is that an individual will hear voices talking inside their heads. And that clearly is an increase of activity. And the voices are commenting on what somebody's doing, and very often they're pretty negative about what people are doing as well. But that's clearly a positive symptom. But there are negative symptoms as well. And so very often, people suffering from schizophrenia withdraw, become uncommunicative, etc. Can you see the slides all right, like this? You all right? Yes? Good. So, two sides to that. But on the right-hand side, depression, down, there's mood, Parkinson's, loss of movement, Alzheimer's, problems with memory, comprehension, language output, etc. So, classifying the disorders like that enables us to think about what we can do in terms of treating them. But first, let's just look at what are called degenerative disorders, because there are three. And these are possibly three of the major brain disorders in terms of how common they are. So stroke, we kind of mentioned, could be anywhere. We don't know the missing transmitter or transmitters, so we can't treat it. Parkinson's disease is death of neurons, but here we know that those neurons are dopamine neurons. We can't put neurons back. There are hopes that maybe people have tried transplanting cells into the brain. It basically doesn't work. People are thinking about stem cell therapy, manufacturing cells into neurons effectively and putting them back. We're nowhere near that either. But in Parkinson's, because we know the transmitter, we can do something. Now, Alzheimer's disease is basically a series of lesions of the central nervous system. Acetylcholine is implicated in that. But we can't control it particularly well. And the reason is if this flipping lamp signal would disappear. Underneath there, in that green box, it says CNS. The arrow arrow in the middle says autonomic, and on the right it says motor. Because that's basically what acetylcholine is doing. Neuromuscular junction, autonomic nervous system, and brain. So the minute we try and increase acetylcholine in the brain, we increase all the autonomic nervous system, we increase all the motor systems. And so the side effects are catastrophic. And that's the problem there, because acetylcholine is a peripheral transmitter and it's a brain one. So to kind of remind you of the life of a transmitter, what we have here then is a series of steps. And these occur, as you can see here, in the nerve terminal. So this is dopamine. This is the transmitter that goes wrong in Parkinson's. It's got other roles as well. There's a precursor, which very often is simply diet. One step or two maximum, and we've got the transmitter. And the enzymes that are catalyzing these stages are high activity. So we can always make enough dopamine. We're never going to run out. There's the process of transmitter release from vesicles, and in the central nervous system, the transport back or the reuptake of a transmitter is very powerful, because this is a synapse amongst hundreds and thousands. We don't want the transmitter to escape and start influencing other neurons, so uptake is important, and then breakdown in the terminal, excuse me, and the transmitter is recycled. Receptor effects, well, those are the same as all the receptors everywhere else. Many are G-protein link receptors, some of them are ion channels. And we can have autoreceptors as well. So, if we think about those disorders and what makes a transmitter and how it works, if we have a loss of transmitter function at the top, we can increase it by a number of principles. We could give the precursor. So, the chemical that's making the transmitter, if we pile more of these guys in, we'll have more dopamine, for example, in that pathway. We could block the uptake. The transmitter sticks around in the synapse for longer and has more effects on its receptor. Or we could block metabolism, and so, again, it's there for longer. So we're increasing the levels of the transmitter. What we could also do is bypass the transmitter itself and give a drug that works at its receptor or receptors, and that would be an agonist. When it comes to deficits, so that's increasing neurotransmitter function. If we want to decrease neurotransmitter function, we've got hardly anything we can do other than give an antagonist that will basically counteract the effect of the transmitter. So we're giving an antagonist of one of the transmitter's receptors and reducing its function that way. Now, there's two sides to the coin, because if you remember on Wednesday, the two major transmitters in the brain are glutamate in terms of excitation and GABA in terms of inhibition. So if we had something like epilepsy, which is a very clear excess of activity, we've lost control of our muscles because our brain areas controlling them are too active, and so muscles are contracting and convulsing when we don't want them to. We want to restore normal activity to balance. We could increase neurotransmitter function through the inhibitory system. So, we're here, we've got homeostasis, epilepsy, too much excitability. If we increase inhibition through GABA, we match the excitation and we balance everything again. And there are many drugs in epilepsy that work in that way for GABA. But we could equally decrease the excitation. We could reduce excitatory systems. Glutamate is the clear excitatory transmitter in the brain, but hopefully you've kind of got the idea with glutamate, that because nearly every neuron in the brain responds to glutamate, if we're trying to fix epilepsy, we're going to mess up most other functions of the brain. And so we basically haven't got drugs that work on glutamate because we can't selectively target the bit of brain to do with epilepsy and ignore other bits of the brain where we need glutamate for memory, we need glutamate for our responses to the outside world, to stay awake, etc. But we can use drugs that block ion channels, and sodium channels that are generating action potentials, and calcium channels that are releasing transmitter. If we block those, we can reduce excitability and bring the balance back. So the point is then that if you just look at these principal slides, you'll see drugs in the CNS that might be precursors, might be drugs that block uptake, drugs that work on enzymes for metabolism, agonists at receptors, antagonists at receptors, and drugs that work on ion channels. That gives us a kind of range of agents we can use. So that was epilepsy. Too much activity. But pain is exactly the same principle. All of you have quiet pain pathways, but if the person next door to you takes the end of lid off their biro and jabs it in your calf, it's going to be really painful. And those pathways become active. And the principles are the same, except we have inhibitory opioid systems. Peptides in our brains that are called opioid peptides because morphine from the opium poppy can mimic their actions. So we don't bother with GABA for pain. In terms of inhibition, we have an opioid system that's pretty specific for controlling pain. And when you look down here, for decreasing neurotransmitter function, it's exactly the same as with epilepsy. We block ion channels, sodium and calcium, glutamate receptors, which is good. But if you recall, we also have some peripheral pain mediators, that when you damage tissue, you have these prostaglandins, so you might take ibuprofen that blocks their excitatory events and works. And pain is the only example of a disorder of the central nervous system where some of the drugs are working out in the body and stopping those messages coming in. All the other disorders, the drugs are working on the brain mechanism. So pain is the only one where we try and stop the message getting into the nervous system. In a sense, we've got more scope. So examples, Parkinson's, we give a precursor. Drugs for depression, uptake blockers. Pain, morphine and opioid is an agonist. Schizophrenia, the drugs we use are antagonists. And on Sunday next week, I've kind of temporarily forgotten, no, Monday at 2, I'll be talking to you about drugs of abuse. And there are some, and they have a pharmacology that's pretty much the same as the medical drugs. So cocaine and ecstasy work on uptake, just like antidepressant drugs. And these guys work on receptors. In fact, they're all agonists at receptors. So non-medical drug use doesn't use a completely different pharmacology from the medical drugs. It's working on the transmitter systems in a very similar way. But there's some problems. So transmitters have multiple receptors. Transmitters, because there are so many neurons in the brain, we've never found a transmitter that does one thing. They always do multiple functions in different parts of the central nervous system. So giving a drug to work on the bit that's gone wrong is also going to change other functions. Receptors might up and down regulate because very often the central nervous system disorders require long periods of treatment. So somebody with chronic pain, for example, might be treated for their lifetime, epilepsy, likewise, and some other disorders as well. And so the systems that the drug is working So that as blood vessels enter the spinal cord and brain, they gain an extra membrane around them, and that must be there to stop chemicals in the blood escaping into the brain. They could be toxic, but it also means that many drugs that probably work brilliantly on CNS disorders, if they can't cross that barrier, they never get into the brain, they're never going to work. And so it's a major problem of therapies, and then long-term changes, well, the fact that, as I said, we've got quite often lifetime treatments, and some transmitters can coexist. So this is this blood-brain barrier. Here's noradrenaline. So you know noradrenaline in the autonomic nervous system, but these are noradrenaline pathways in the brain, in the spinal cord, in the cerebellum, in the cortex. So these brain pathways go wrong in depression, for example. We might like to target this bit of the brain or this one or this. We can't. We just have to flood the brain with the drug. But any drug that works on noradrenaline will find its way to the autonomic nervous system in the heart without any problem. It's in the vasculature. But these extra membranes that make the blood-brain barrier up means that it may never enter the central nervous system and consequently doesn't work. So, we're going to race through disorders. It's kind of a bit mean for you and me that we have to do disorders in one lecture, because normally it's a course. But anyway, we're going to do it. So, epilepsy. These are all kind of overviews, and I've kind of set them up in pretty much the same way, where we'll look briefly at the disorder and then look at treatments. So, too much activity in parts of your brain that are controlling movement. So, you make a decision. I'm going to hang around for this lecture, or I'm not. And let's say you decide to go. You choose that, and your brain activates the correct muscles so you can lay it down. If those areas are overly excitable, muscles convulse, and they can be generalized in many parts of the body, partial, a smaller area, and a particular type of epilepsy, which is almost paradoxical given it's too much activity, but an individual suffering from that often loses consciousness, and they're called absence epilepsies as well. So here's the problems. So what's going on? Excess glutamate or reduced GABA. There's too much excitation. It could be either of those. Gain of facilitation, loss of inhibition. So we want to put back those that normal activity. We've gone from a baseline to excessive activity. Epilepsy is classified as partial and generalized, and then other parts of that. And it's a disorder where the subtypes of epilepsy have got different treatments. So we know that all procedures aren't the same, and we have different drugs for them. So here they are. Now, these squiggles on here are basically electroencephalograms, where we can put electrodes on the skull and measure the activity within the brain through the skull. We don't really have to do that with epilepsy because it's kind of obvious. Movement is abnormal, you can see that. But you can see the abnormal activity. And it's the one disorder where we do have an objective measure, abnormal activity in the brain. So what could we do? We could enhance inhibitions. This is the GABA-A receptor. There are some drugs called barbiturates. So what I've done is give you the class of drug, one example, and how they work. The barbiturates open the chloride channel that the GABA receptor A works through. The benzodiazepines modulate the GABA-A receptor. So barbiturates opening this channel are likely to produce, if you get the dose slightly wrong, a massive inhibition of the nervous system, because they jump past GABA, they jump past the receptor, and they open the channel. They are used as anesthetics. If you go for surgery and before you have your mask on and you're breathing an anesthetic, you have an intravenous injection of barbiturate at a high dose, and within 3 seconds you're unconscious. So the doses in epilepsy have to be much lower, and the benzodiazepines that work to modulate the receptor are gentler and safer and tend to be used much more. Barbiturates might be used in very severe cases. There are some other drugs that are poorly understood that block the uptake or breakdown of GABA. But all of these are increasing GABA function. Or we could reduce excitability. The drug there, carbamazepine, so the drugs with italics, is a sodium channel blocker, and gabapentin is a drug that modulates calcium channel activity. So you might go, yeah.
Why is that epilepsy can be induced by flashing lights?
Okay, yes, so that is a visual input into the central nervous system, and it would appear that when the neurons are kind of hyper-responsive, the visual inputs become amplified and too large, and very often, if you have an excess of visual information, we might start to escape from it, and it's almost a kind of response to that. Those flashing lights are bright. For most people it's okay, but the hyperactive neurons, it's almost like it induces an escape from the light kind of response. Okay? Good question. If we block sodium channels completely, we have no epilepsy whatsoever because we're dead. So the doses of the drugs that work on the sodium and the calcium channels have to be kept quite low, and the idea is that maybe they'll selectively reduce the abnormal activity and leave normal function unaltered. Okay? But the major problem is reducing excitation, increasing inhibition, sedation. It's fine controlling somebody's epilepsy, but if they're sleepy and can't concentrate, you can't live a normal life. And so we have to be really aware of side effects. So anxiety. So you have this exam at 10 o'clock, the secrets of what you don't control. But if you go to an exam or go on a date or whatever and you're a bit anxious, you will generally do better. A little bit of anxiety makes us function better. But if it's too much and we start panicking, having phobias, when we become agoraphobic, for example, don't want to go out, don't want to interact, excessive compulsive behavior, and very often, after a stress, people can remain anxious for long periods of time. So, it's a disorder of mood. Epilepsy was a motor system. Here are the symptoms. We've got too much activity. Again, we've gone from normal mood to excess here. And it's the same drugs. Those benzodiazepines, here, like diazepam, like drugs, they are enhancing GABA function. We've got too much activity, so they work in anxiety, just like they work in epilepsy. The doses are different, they're lower in anxiety. Or we could enhance the inhibitory function of this transmitter 5-HT, and this is a drug that does that. So we've got two ways where we're bringing down excessive activity. Okay? Schizophrenia. This is the one where we have these positive and negative symptoms, so it's never going to be quite as easy. Here, the problem is dopamine. There's too much activity in a particular dopamine pathway. But here's a really important point. This came about by observing these so-called positive symptoms, giving drugs that were antagonists of dopamine, the dopamine receptor, and here's an example of one of those drugs, and it was found that those drugs reduced schizophrenia. Two important points. At that time, the treatment for schizophrenia schizophrenia is that you would probably be locked in a padded cell, put in a straitjacket, and given a lot of very bizarre therapies like insulin-induced comas, cold water baths, like let's shock the nervous system back. It was inhumane, didn't work, a disaster. And the drugs came along. But these drugs were first given to patients with schizophrenia because they were known to calm down people, make them sleepy and quiet. But it actually turns out that they work on those symptoms, particularly the positive symptoms. They work on the agitation, those hallucinations. People often become paranoid and have delusions. They work well on that. And it's the dopamine 2 receptor. But these drugs don't work so well on some of the negative symptoms, like the withdrawal, catatonia, basically not moving. And there's a drug called clozapine, which works on dopamine 2, maybe also 5-HT. And that seems to work on some of those positive symptoms. But we mustn't presume that because the effective drugs block dopamine 2 receptors, that is the cause of schizophrenia. Because it's quite conceivable that here is your dopamine neuron, here's your dopamine 2 receptor, and the drugs are going to target that. But it could be, normally around, that's the way synapse goes, to keep drawing these. It could be this neuron that's gone wrong. And as a consequence of a problem here, down the circuits, this system becomes overly active and generates the symptoms. So there's very little evidence that dopamine is the cause of schizophrenia, but it's driving the symptoms. And in fact, it's most likely that it's glutamate back here that initially goes wrong. So you kind of okay that as a concept, that it works on the symptoms, it's not necessarily the cause. Yeah, question?
It's been shown that most, or a large proportion of schizophrenics smoke cigarettes.
Mm-hmm.
It's been proposed that it's some sort of method of self-medicating.
Yeah.
What sort of system would that be working on?
Okay, so if you're smoking cigarettes, you're going to activate nicotinic receptors. So it could be, for example, this might be an inhibitory system that controls that, but it may be activated by acetylcholine, acting on nicotinic receptors. So we activate the inhibition and stop that going on, or some circuit-like effect. It's a good point. And at the bottom, the side effects. And I need to read them out of this stupid thing. Motor disorders. So you treat with these drugs, people don't move as much. Sedation, flatness of mood. But may trigger, underneath, Parkinson-like effects. So let's look at Parkinson's. Parkinson's, as I mentioned, is a disorder of dopamine. So here are these dopamine pathways. And there's an area of the brain here called the substantia nigra. What colour are neurons? Genuine. I mean, clearly you haven't seen your own neurons, but white? Remember white and grey matter? Do you remember the difference? Grey is the neurons, white are the axons. Yeah. The neurons are grey. They're kind of pretty dull and inconsequential looking things. In the substantia nigra, there are some black neurons because they have a pigment in them. And as a consequence, and it was kind of lucky in a way, when people started looking in post-mortem brains, looking like this person's got Parkinson's, can we look and see what might have happened? If it was a bunch of grey neurons amongst all the other 50 million, you'd probably you'd never notice, but somebody did spot that those grey neurons had gone. And then it turned out that those grey neurons were projected up into the motor parts of the brain, and it was a reduction in dopamine function. So, schizophrenia, increase in dopamine function, Parkinson's, decrease. And the dead neurons in Parkinson's are in the substantia nigra. The dopamine problem in schizophrenia is here in the cortex. So the same transmitter, but different neurons, different locations. So if you're treating schizophrenia and reducing dopamine function, in a normal individual, you might trigger Parkinson's, because your drug is reduced here. Likewise, you're treating Parkinson's, you're trying to increase dopamine in this area, and consequently, the patient can have a psychosis. So in the case of Parkinson's and schizophrenia, it's very important to get the right dose. So people with schizophrenia, their symptoms go, but they don't get Parkinson's. Parkinson's don't induce schizophrenia, and it's because of this. So dopamine has functions in cognitive function, schizophrenia, in movement, in nausea, and in reward. And this little pathway you might be interested in, and we'll talk about this next week. This ventral tegmental area. So anything in your life that you quite like and quite enjoy, at the moment, you're going, actually it's pharmacology lectures, but it could be chocolate, or social media, or crystal meth, or something else. But basically, there are many, many things that trigger activation of these dopamine neurons and trigger reward, reinforcement, and that's why we decide that we'd like to do that again, given the opportunity, or we become completely addicted to that. So I know there are several of you who sleep in this theatre overnight, so you're ready for the next lecture. That's kind of excessive. So, what have we got with this problem, this issue of Parkinson's? We've lost dopamine function. The neurons have died. So what we need to do is increase dopamine activity. So there are two ways to do this. Remember those principles? Now we give this precursor. Can you bother to go back? Yeah, fine. Let's go back. On the dopamine synapse here. Here's the dopamine. 80% of these neurons have gone. 20% left. We can't give tyrosine. It doesn't get there. But we can give dopa, this precursor. So we load the patient up with big tablets of dopa, and because this is long-term therapy, and these are elderly patients who might forget to take their tablet twice a day, very often the dopa is given in a slow-release preparation, so it's working for long periods of time, which helps the elderly patients and maintains the dopa levels, and that gives us more dopamine. The other approach is here an agonist of the dopamine 2 receptor. Remember, that's the same one as in schizophrenia, but that can cause nausea and psychosis if we give too much. And very often we give another drug that prevents the breakdown of dopamine as well. So it's very often a kind of combination therapy, and it's highly effective. Patients have rigid muscles and a tremor. So if you ever wake up in the morning after a big night out and going, oh my God, I've got this tremor, you haven't got Parkinson's unless all your muscles have got locked rigid as well. Everybody's got a tremor, but even the tremor for a patient, it keeps going on, you can't do fine movements, your muscles are rigid, it's hard to move around the world. And here's that pathway in the human brain. It's actually a tiny number of neurons, and it runs from that substantia nigra into a part of the brain called the striatum, and this pathway we absolutely need in order to carry out any movement. And it could simply be that all our lives we are moving. This pathway works an incredible amount of time, and in a sense it might wear out, because Parkinson's is a disorder of old age, although sometimes it can be triggered in younger people, sometimes by drugs, often by a head injury. There are examples of boxers and also footballers in the past, where if you played football in the winter, the football soaked up water, you're on a muddy pitch, if you headed it, you basically had a concussion. That can trigger it early, but generally it's a problem of old age. And what we can do in the human brain is do a scan. Scans just normally look at activity, but this is a scan where the individuals have been given a tracer for dopamine, so it'll stick to the dopamine neurons. So at the top you see the normal brain, 2 substantia nigra. In Parkinson's, the big loss of neurons, the treatment brings back that dopamine function. And it's one of the few examples where we can look and see pharmacology working in the brain. But many of the patients, and this has only been kind of quite recently recognised, because they're all slightly embarrassed about this, the treatment works, so you can go out shopping, you can play with your grandchildren, you can write, you can do anything like that, and your movement's back. And patients rather embarrassingly said to their doctors, "Thank you so much, everything's great, except I've got hardly any pension left, because I keep wanting to go out and gamble, I've got compulsive shopping, and even though I'm an elderly patient, I have some strange sexual urges as well." And this is because enhancing dopamine in the movement pathway, by this, also activates that reward pathway. And so the therapy for allowing the patients to move is triggering compulsive behaviours, and there we are. So, here's the precursor, L-DOPA. It converts to dopamine. We need a big dose of L-DOPA to get into the brain. And there are 2 drugs called adjuncts, because the problem with Parkinson's is that we've got to get the dopamine levels exactly right. We don't, we're going to trigger reward, nausea, schizophrenia, etc. So this drug, selegiline, blocks the breakdown of dopamine in the brain. So that's given alongside L-DOPA, and we can reduce the dose. We want to reduce the dose as much as possible and get dopamine in the brain. But DOPA is metabolized to dopamine outside the central nervous system. So this is in the circulation, and transmitters basically can't ever cross the blood-brain barrier. So if we give L-DOPA and it converts to dopamine in the body, the therapy is useless because that dopamine can't get in. So we give another drug called carbidopa that blocks that enzyme. So the breakdown outside the CNS is prevented. L-DOPA now gets in, better, we reduce the dose. We reduce the dose a bit more by preventing the breakdown of dopamine. And now, with this rather complex therapy, we can get the doses exactly right. And so it's a really quite remarkable example of how combinations of pharmacological agents can be used to put back a missing transmitter at pretty much exactly the level it should have been. So this is Alzheimer's, it's cognitive disorder, and we said the problem is acetylcholine, problems in the central nervous system, but a peripheral transmitter. So a drug that barely works is a drug that blocks the breakdown of acetylcholine in the body. It can only be given at low doses because we don't want acetylcholine to get high in the neuromuscular junction or the autonomic nervous system. And so the effects of these drugs that increase the levels by blocking the breakdown are marginal, and we need to do better. Right, need to speed up a bit. Depression. So you get rather depressed depressed when you look at your bank balance or your exam results or whatever. That's kind of fine. That's called reactive, and we kind of bounce back. But major depression is where your life is the same, but suddenly, due to some endogenous change, mood goes down. Reactive is okay, but if it becomes prolonged, it needs treating. And bipolar are these swings from excessive mood to depression. And it's no point to say to somebody, look, you know, sort yourself out, cheer yourself up, you're going to be fine. It's not like that. Something's gone wrong with the pharmacology of the central nervous system, and the major issue is a disastrous one. The risk of suicide in depressed people is huge, particularly in young males who don't communicate as well as others about their feelings. So it's a mood disorder, people withdraw, lack of interest, worthlessness, etc. It seems to be a reduction in the function of noradrenaline and 5-HT. So what we need to do is increase the uptake, increase their activity, and pretty well now, the drugs that are used block uptake. Previously, drugs that block the metabolism were used, but they were pretty unpleasant drugs. So fluoxetine is a drug that selectively increases 5-HT, and the triptyline is a drug that increases the levels of both those transmitters. And so it's noradrenaline, 5-HT. All the drugs work on those in one way or another. But their pharmacology happens pretty instantly. But you have to wait for the treatment to work, probably about 2 to 3 weeks. And so even though the pharmacology kicks in, you need to keep the levels of those transmitters high for several weeks before you bring things back to normal. So alter the levels, as I mentioned. Most of the drugs block the uptake. In the old days, block the breakdown. These drugs called monoamine oxidase inhibitors. We've got the selective serotonin reuptake inhibitors, serotonin selective reuptake inhibition. Other drugs, SN, serotonin, and noradrenaline, as you saw. And we increase the synaptic levels by doing that. And many recreational drugs work in a similar way. So, pain, none of you have at the time, at the moment. Pain is possibly, well, it is the most common disorder. It says 12% of the population, that's 12% of every population we know with severe, long-lasting pain. It's probably more like 20% when you take all pains in. It might be caused by trauma. Doctors are very good at causing pain. The surgeons who do the surgery and then jump in their car and go to the golf club, they cause the pain. Low back pain, arthritis, phantom pains, pains where people have had a limb amputated and still feel pain from their imagined hand or leg or whatever pains. So that was the opium poppy. Morphine is in the opium poppy, and morphine works on what are called opioid receptors, and there is a human opioid receptor. It would be kind of weird if we had evolved the receptor just when we had that long weekend in Afghanistan and wandered into a little poppy field and thought, I'll just eat that poppy, that looks good, and peckish, and taking morphine like that. It's never going to be like that. It's the endogenous opioids that are peptides, that are transmitters for this receptor, and morphine comes in and works on that receptor. So this is what pain is. Pain receptors in the body get activated. Glutamate and peptides take that information into the spinal cord, and the spinal cord has a map of your body. So if the person next door to you sticks a pin in your toe, the lower end of your spinal cord is activated. If they happen to stick that pin in your ear, it's higher up, and that goes through to the cortex, where we locate and describe the intensity of our pain. unless you have a hobby that kind of involves a bit of leatherware and a whip now and again, that's going to be an unpleasant stimulus, and so our emotional brain becomes activated at the same time. Fear, aversion, I don't want to do that again, and that involves noradrenaline and 5-HT, because they're important in mood, anxiety, etc. So, we could inhibit in the brain, or we could inhibit in the spinal cord. And so, we have drugs like ibuprofen and aspirin. This still is so annoying because ibuprofen and aspirin working on the activation of the pain receptors. So they're working outside the central nervous system, blocking prostaglandins that are activating those receptors. Okay? But when we come on to this limbic brain, we can use antidepressant drugs, the ones you just saw, because by changing noradrenaline and 5-HT, yes, they work on mood, but this is another role on pain, because the same transmitters activate a pathway from the brain back to the spinal cord that inhibits pain. So drugs used in one medical disorder with a pharmacology can be used in another. Antidepressants for mood, antidepressants for pain. And then those opioid receptors, they're found in the spinal cord and brain. They primarily inhibit transmitter release and postsynaptically inhibit neurons. And they're doing that because this opioid receptor is coupled to potassium channels. So we activate this receptor with the drug on the outside, we open potassium channels, and we hyperpolarize and inhibit. So you give somebody morphine, it works in the brain on these descending inhibitions, it works on the spinal cord and inhibits there. So two powerful ways of inhibiting pain. The spinal cord as the messages come in and within the brain. And that's why morphine can be such a successful analgesic drug. So, the endogenous opioids are kind of interesting because placebo, which is an inactive compound, producing a therapeutic effect, activates opioid receptors in the brain and activates a descending inhibitory pathway. And in the case of placebo for pain, that's how it works. So this is an example of a psychological event. You're given a tablet, you don't know whether it's the active or the inactive, but you hope, you expect it's going to work. And that psychological event works on the pain-controlling pathways, uses endogenous opioids, and triggers a reduction in pain. So never think that psychology and neuropharmacology are different. They're all part of what we are. So we have these drugs, aspirin and ibuprofen, working on the periphery, morphine working in the CNS, and don't forget lidocaine, the local anesthetic that's used to block pain transmission through sodium channels as well. So those are those drugs there. Morphine blocks the release of pain transmitters. Sensory affective parts of the brain are reduced. But here's the problem for the last couple of minutes. Everybody could wander around with morphine and never have pain. The whole world would be pain-free. If it wasn't for the side effects. Respiratory depression, morphine slows down your breathing, it stops you coughing, it sends you to sleep. So Morpheus might well have been the bloke in the Matrix, but the first Morpheus was the Greek god of dreams. And they named morphine after him because it makes you go to sleep. So, you've bought a white powder on the corner of Gower Street because you think it's Friday, that's kind of what I do. You're in hospital, you're given a tablet of morphine, we know exactly what it is, it's 100% morphine, and we know the dose. You take this white powder that's heroin. Your breathing slows down. You start falling asleep, you vomit, but you can't cough, and you basically die pretty quickly. So, heroin and morphine have identical pharmacologies. Morphine is safe because we know the dose and its purity. Heroin you don't. And so these combinations of side effects are a major problem. So yeah, if you vomit, you're falling asleep, you don't cough it up, you choke on that, and your breathing's stopping anyway. You could be saved by a drug called naloxone, which is an antagonist of those opioid receptors and will block all the effects of heroin or morphine or what have you. So that's about the overlapping. The very final point, some of you just to read as we go, that genes make everything in neurons, and there are a number of examples where transmitters alter gene activity. We have individual genetic variation, and part of that might protect us against CNS disorders, others might predispose us, and there are some rare down here mutations in the brain of calcium channels, sodium channels, and GABA neurons that cause disorders. But the majority of the disorders we're talking about, that's the overall list here, are just due to changes in life and changes in us. So have a good weekend, and I'll see you next week, and we'll delve